another lunch and learn Mondays.
Monday.
So we thought we would, I feel like this is like our little newscast, right? We're bringing articles,
So
educating the masses, trying not to be fake news. So what do we want to talk about? We've got a subject.
We are talking about neuromodulators.
Yes.
And Dr. Palm has an exciting article in her lab because we do have an announcement that there is a new indication or new area that's FDA approved. So we'll talk about that. We, have an array of options now with neuromodulators, and they all have little subtle differences. I think we all use them, differently as injectors across the board. Everyone has their preferences, but we wanted to talk a little bit about specifically areas of injection, and there's more well-known on-label areas. I think one thing we specialize a lot in this office is off-label areas of injection, and one of the areas that has recently been approved is something that we've all injected for quite some time, and it's a wonderful area. It's probably become one of my favorite areas to inject, I'm sure you as well. So just talking a little bit about that and what the options are, because a lot of patients don't know that these are even options. They've had Botox for years and years and years, and they come in and we start talking about other areas that could be treated, and they never have been told that before.
Yeah, so I think that's great. So, this is hot off the presses. It was a press released, I think, at the end of last week, and so we thought, gosh, this is so timely because we wanted to talk about sort of more esoteric or interesting or creative ways that we're using neuromodulators in interesting areas. So Botox cosmetic, which is one of the 4 toxins we've got here on this tray today. There's actually 5 currently approved in the U.S. and there'll be more coming, which we've actually been involved in some of the studies for. But we were actually involved in this study. So we were a part of the phase 3 clinical trial for Botox cosmetic being injected in the neck. And you think, well, why are we doing that? Well, because there's a magical muscle called our platysma. And you had said it's been a while since you've done it. So yeah, you're doing such a good job right now, Julia, demonstrating it. It's the muscle that makes us go, ugh. And that's what we actually, it's pretty good. Yeah, it's been toxed. So hopefully it's still hanging in there. But it's a great muscle to treat because it starts in our lower cheek area, it drapes around our jawline, it goes all the way down our neck, and it ends in our collarbone. And its job is literally to do this to the face, which this is not amazingly attractive. So there have been some really interesting studies that we've done. We'll talk about the pivotal trial that we were involved in, but 2 years ago and then a year ago at our American Society for Dermatologic Surgery, actually using Xeomin, which was botulinum toxin type A, they did treatments of neuromodulator along this part of the jawline, which is treating just those superficial fibers of the platysma. And they did a couple interesting studies. So the first one that they presented a couple years ago showed that when we treated this and you put mirrored images, so somebody's baseline and then their after treatment and ghosted it on top of one another, they saw sharpening in the jawline. So we're probably getting some of the platysma, they were probably getting a little bit of the DAO, which is this muscle that goes from the corner of the mouth down to the jawline. And so it helped relax the platysma and sharpen the jawline. Now, based on that, the next year, they actually showed with the botulinum toxin, but any of these would perform similarly. They looked at differences in the midface. So you can imagine if we've got something going like this, if you relax it, it actually showed volumetric changes in the afters when we ghost image things over one another of the equivalent of doing about a half a syringe of filler on either side of the cheek. So we definitely know, like, the top talks to the bottom and elsewhere. I tell patients, especially with muscles sort of softening and when we're doing sophisticated things with toxins, it's like pulley systems. When we soften one, another one is going to express it sort of more significantly. And I think, that's something I really impress upon patients. I probably get once a month, somebody's like, I did something naughty, Dr. Palm. One of my friends went to a Botox party at some unnamed place, and I got toxin, and look at my brows now. Or I'm sure you've seen that too. And I think unfortunately sometimes neuromodulators and the practice of it gets commoditized, but there's an art to it. So, maybe in the upper face, we'll talk about that first, but then I want to talk about like all the interesting places we do things, because the bread and butter is probably upper face, but we talk so much about balance in the lower face too. So what are some of the things that you're looking at in the upper third of the face, and how do you achieve that like lifted brow, opening of the eyes, treating the frownies? Like maybe speak to our audience a little bit about that.
Dr. Palm is spot on. It really is. Everything works together. It's not something where you treat one muscle and it immediately has an effect on the muscle that it's next to. So when we're looking at the upper face, I'm always looking at symmetry, brow position, lid laxity, and of course patients' concerns. Some patients, they come in and they say, I have this deep crease across my forehead that drives me crazy, but their brows are already like here. And if I Botox that or distort that and try to make that really flat, and that's all I do, you're going to feel even heavier. And so there's a lot of little details that make the biggest difference when it comes to placement and depth of placement. This treatment, I went to a cadaver lab a few months ago, and the doctor leading it was mentioning that he thinks that this should be one of the last things injectors learn instead of one of the first things, because it's actually one of the hardest to perfect. And I think we can all appreciate, your patient is walking out of the office and you don't really know how things look the day they leave. It's only 2 weeks later, when things really settle. And I think that everyone's anatomy is a little bit different. So it really takes somebody that understands every muscle, every depth, where its origin, where its insertion is, and how you're treating that as a whole. Because I've had a lot of patients who have come in and said, okay, one time I had my forehead treatment, and personally this even happened to me the first time I had my Botox treatment. My frontalis, which is the muscle that elevates your brows, was the only thing treated, and I thought, wow, my forehead looks nice and shiny and smooth, but why do I feel like I can't even move my brows, and what's happening to that? And when we look at kind of indicators of beauty and youth, understanding that not everything is about lines on the face. It's also about, how open the eye is, the arch of the eyebrow. There's so many other little factors that us as humans recognize when we're looking at a face. And so really making sure that our approach aligns with the patient's goals, but that we as injectors are also putting together the entire picture, making sure that it all will aesthetically make the best impact for them.
Yeah, and I think important to have somebody injecting you that understands that artistic approach, because for example, with the forehead muscle, we talked about it, it's called our frontalis, and it helps move our eyebrows up, but it actually forces our hairline down, so it acts like an accordion. It goes in 2 directions. And if you raise your eyebrows up, and I'm talked, so it's a little harder, but if we see, raise up again, usually that second forehead line that we see, that's about where what we call the line of convergence is, and that's that point. It's usually about 2/3 up the forehead, 1/3 down, that bi motion of the forehead is. So the upper third of the forehead is a really safe area to inject. We can raise the hairline a little bit. It won't affect brow position, but playing in that lower 2/3, especially in patients that recruit their forehead muscle to maintain the brow position, we have to be really careful. I will sometimes do micro jogs in a couple areas to not take resting tone away, but just some of the dynamicisms of that away. But it's an area that we have to be so careful with, because I think that's where patients come in and say, oh my God, I feel like I have an anvil on my forehead. I was treated elsewhere. Like, what do I do, Dr. Palm, to help this? And we can help some recruiting, adjacent muscle groups to help with that, some of that. There was another interesting study about injecting salt water and maybe lessening some of the effects. And the depth of injection, which you mentioned, really makes a difference in the forehead. So there was a study where they injected deeply, thinking that a lot of where the nerve catches the muscle is on the underside of that muscle belly head, on the frontalis. And so if we're injecting deeper, you hear that crunch, and it's often a lot more uncomfortable, but you get more of an effect on the forehead. I personally don't do that on 99% of the patients for a couple reasons. A, the crunch hurts. B, it dulls your needle. And C, most of our patients, we're not doing, if we're talking about Botox and in units, the on-label for the forehead is 20 units. Like, is that what you do on most patients? It's not for me. I mean, it's usually like 6 to 10, 4 to 10 units, depending on the person that you're using. In really active forehead muscles, I have like 3 women in my practice that I call my incredible Hulk ladies, because they use a tremendous amount in their frontalis, but they're very much the exception, and those are the few patients I actually inject deeply. Most people I'm injecting superficially. I don't want to get, if you look at that study, people's forehead is totally gone, and their brow position was completely flattened. Like, if I was creating that aesthetic result as an outcome for patients, they would be so unhappy for me. So it's one of those things like I took from a study and I was like, that's not how we should inject unless it's one of these people that we're trying to recruit every single neuromuscular junction that we can. They're overactive frontalis. I want to get at that big juicy muscle and soften it as much as we can. You know, and then convention with like how we inject the frown lines, so-called the glabellar complex, has changed a little bit. So if you look at the package insert of any of these, Daxify, Dysport, Botox, Xeomin, and Jowett, we don't have here, but that's the 5th one that's approved. They talk about injecting a centimeter above the forehead. So is that, or above the brow, I should say, is that typically where you're injecting?
Typically no, and I think, you know, a lot of times when I'm talking to a patient who has had Botox or Dysport, maybe they've had a bad experience with it in the past, maybe they just read about bad things that have happened. We in this field are constantly learning, and so what was best practice 5 years ago, 10 years ago is maybe not today. And part of that has come with, you know, a lot of understanding of anatomy, specifically of the glabellar muscles. There are muscles that kind of pinch together, and, you know, they interdigitate with the frontalis muscle that helps raise the brow. So historically, when you're treating, you know, you're using the brow as an anatomical landmark, that already is a variable. And then if you're injecting a centimeter above that, the reason we were doing that is, you know, to decrease the risk of causing one of the potential complications, which is lid ptosis, so to make that a little bit safer. But now knowing that you're actually going to be hitting those frontalis fibers, and a lot of patients back in the day would kind of walk around looking like this, like they're angry, and, you know, people say, I don't want the Spock brow, I don't want to look weird. One time I had it, my brows dropped in the middle, and so you have to be more cautious on injecting lower and, you know, really truly in the muscle origin. You know, and then more superficially and cautiously in the outer portion of the insertion. So there's a lot that's come with knowledge and understanding, and we're constantly going to be advancing techniques and making things, the outcomes better and the outcomes safer.
I think crow's feet too, I think that convention has changed a lot. So again, if you look at on-label dosing, I think it's 12 units per side if we're talking about Botox. That's a lot. That is a rare person that I'm injecting that much. They have to have really thick muscle belly, you know, this O-shaped muscle called orbicularis, which is, you know, a sphincteric muscle, meaning it closes the eye. And so when we treat sort of in the upper sort of tail of the brow, and when we treat around here, it relaxes crow's feet and allows for this chemical brow lift that we can create with the neuromodulator. But I really am very careful. I think, you know, you can be a little generous in the tail of the brow, but I typically will be light, and I will graduate the amount I'm doing as I go down what we call inferior, down sort of the crow's feet. Because if you take too much of this action away, what happens to patients?
Like this.
Yeah, so they don't have an authentic smile. A third of our smile, which is called our Duchenne smile, comes from our eyes. And so I tell patients, we don't want to take that away. That authenticity of how we're expressing is so important. So that's number one. Number two, that orbicularis muscle, it is like a corset. It holds in our infraorbital fat pad, which sits here. It helps with our lymphatics. So in the same way our calf muscle helps in getting sort of our blood back to our heart, those that muscle is helping to kind of keep some of the fluid in. We all know if we've been sleeping overnight and you're over a certain age and you've had too much salt, you know, you end up getting puffiness under the eyes. And so that having action of that muscle helps kind of squeeze over time with our lymphatic channel some of that out of the way. So you can see shelving out if you do too much. I think you see a little bit of atrophy, meaning muscle thinning in that area. But also I think you can see problems with festoons and liquid accumulation. So edema is our term for swelling in the under eye. So I'm always real careful in that area. Now, in the upper three, what's the other muscle group that we treat a lot when we have softness here, softness here, softness here? What's this muscle? Yeah. And I see a lot of patients, if they're new to us, coming in and they've never been treated in that area. And to me, you know, we talk about the upper three muscle groups, you know, treating the glabellar complex, treating the frontalis, treating the crow's feet. But I think really I almost always, you know, elicit that in patients, especially when I'm first seeing them, and keep an eye on that. Because not everybody starts to recruit, but when you're softened in the area, the only last place you can show displeasure is in
and she's talking about that example, because when you're not moving as much in this area and you're still going to be trying to make these expressions, this can start to compensate, and you know, you'll start to see people with more like deep lines at rest. And over time, that doesn't look natural either. So even if it's something, you know, where you're, you know, maybe not as much movement here, and you'll see patients come in and they're really just pulling a lot of it is from this area, and making sure to address that as well.
Yeah,
is important.
no, I think that's so important. So we've addressed the upper third of the face. Let's move down. So we mentioned this study, which we were a part of, which was really cool. And what's interesting is in a lot of clinical studies we do, people have to be fairly symmetric. Like if we're doing a cheek volume study, they almost always have to have like similar sort of cheek volumes if we're going to restore things. What's interesting with the platysma, so this neck muscle we were talking about at the very beginning, is that it is really asymmetric. So some people, when they make that sort of exactly, they will have one band on one side and two on the other, or sometimes it's two here and one there. And that was nice in that study. We were able to recruit people with asymmetry from one side or the other. And then the volume we used of Botox depended on, you know, a set volume we were doing along that jawline, but then a set volume we were doing down each band. And it really showed, you know, and these studies are hard because we are having to move patients along a grading scale of photos that we have of severity, and then we need to see a duration of time. So meeting some of these sort of litmus tests and barriers to demonstrate to the FDA that we've got a treatment that's not only safe but is efficacious, and something like this is really challenging, and it met that bar. So even though I've been injecting necks for 15 years, and I think someone who made a big impression on me was Dr. Michael Kane. He's a New York City facial plastic surgeon, and he has been doing neuromodulators in really, I think, inventive ways in muscle groups very early on when we were just talking about treating frowns. And you know, he's a surgeon, and he was noticing that his patients he was treating the platysma, over time, their necks are aging slower, and that makes a lot of sense, right?
Yeah.
So we talk about doing a little bit of a wash of a neuromodulator if we're considering doing a calcium stimulator here, or doing an old therapy in that area to have sort of a quiet bed first. And I think if you are consistent with this, so maybe doing it 2 or 3 times a year, in the neck, I do think that your neck ages slower. Because patients will ask me, they're like, Dr. Palm, like, why is it your neck look that good? Well, I've done some things. I mean, I've definitely been really consistent about neuromodulator over time. I've had a collagen stimulator such as Radius put in this area. And then I've had old therapy several times, you know, over the past decade. And I think doing a little bit every once in a while and consistency, I mean, that's the biggest thing. So in the lower face, what are other areas that you find that you're treating for patients?
Well, and one thing to add, I mean, I agree with everything you said, and I think that it's so important for patients, even younger patients, to address this area. So I'm so glad that there's an indication, because it becomes one of the hardest areas to work backwards on later. And so if you are a Dr. Palm who's been doing this, like, her neck is flawless, and you look at that and you think, wow, but it's because there's been little tiny things that have been done over time, and that consistency in addressing that area versus just ignoring it makes a big difference. You know, it's not all just really good genes, it's the little, you know, details.
Let's talk masseters, because that is something like during COVID, I swear to God, there was an epidemic not only of COVID, but there was
TikTok took over, and everyone wanted their masseters treated, and it was, you know, older patients with, you know, hollowing and jowling, and they were like, can I get my masseters treated? So in the lower face, I would say that the most common areas I will treat around the mouth is the muscles that kind of pull down the corners of the mouth, called the depressor anguli oris, and the chin muscle. The masseter muscle is become very popular, very well known, because I think there's a lot of things I could talk about on social media and things that spread, but not everyone is a great candidate for it. And I think that you have, you know, for all of these areas, there has to be a conversation about why you're doing it, what things you'll notice that you might like, what things you'll notice that you might not like. Especially in the lower face, it is definitely, you know, there's much more of an art to it. You have to have a lot more precision, and a dose placement can make a big difference in the outcome. So masseter muscles are part of the muscles of mastication, and when you, for some people, they become hypertrophic, whether they're grinding their teeth, you know, have at nighttime clenching, you might notice that you see some bulking in that area, and that bulking may cosmetically be unattractive to them. They may feel discomfort from that, and so it's an area that's really wonderful to address with neuromodulator. On the negative, if it's debulked too much, and this is something Dr. Palm and I both have talked about in the past, where you'll see patients who, you know, maybe they've had these muscles completely obliterated and atrophy down, And then they have more hollowing back in this area and a little bit more jowling in this area. And so they have to be treated, to a dose that's appropriate to the patient. It's not a one size fits all with that dosing, and making sure that you're not over treating it in frequency. A lot of those patients that I have treating that area, I'll have them do it maybe once every 6 months instead of once every 3 to 4, just to make sure that we're being respectful of that,
Yeah, and we've both been to cadaveric classes, and I think that's a really important, a good injector, I think, understands anatomy first and foremost. Those muscle groups look different. So first of all, our masseter muscle that helps with mastication or chewing, it works along with our temporalis muscle. So when I am evaluating somebody that comes in saying that they have what we call masseteric hypertrophy, so you see them, we look at photos when we're assessing patients, and somebody's starting to become trapezoidal in the look of their face, so like wider at the bottom rather than sort of square as a gentleman or a little bit more tapered as a more feminine sort of appearance. That's something that I ask them about. They think you're a genius. I'm like, are you having issues with your teeth? Do you clench? Are you getting TMJ symptoms? I think we can help a lot of that, but those muscles really look different. So when we go to cadaver courses and we dissect a face, these muscles of facial expression that we're treating with most of the uses that we're using with neuromodulators, they're innervated by a completely different portion of our motor nervous system than these deep muscles. They look different. So like our little pretty facial muscles, they're pink. These are like red-brown. And it shows you they're functionally doing different things in our head and neck. So I think that's number one, really important. We inject these deeply. So it's typically a 3-point injection. We're injecting in the muscle, and I've had a couple patients come to me and have been treated elsewhere. Not only is it just over treatment of this area, which I honestly sometimes feels like it can take a year or 2 or longer to come back, but treating too forward. So really eliciting that muscle action, I think, is really important with that. And then I tend to be very conservative. So if you look in the literature and you look at the studies that have been done treating this area, and you're using the equivalent of units of Botox, they've done anywhere between 20 and 70 units per size. So that's 40 units to 140 units total. In my estimation, that's way too much for most female patients. If patients truly are symptomatic and they're not at that stage that I think, this is like the framework holding up our jawline. It's our lateral face. And so if you do too much to thin it, things drape forward. And like you were saying, you get gel formation. I tend to be very conservative in what we do. I want to relax the symptoms, maybe create slight facial changes over time if that's our goal, if somebody really has bulky masseters. But we want to be really careful that we're not just walloping. And I think if you're going to a place where it's more about numbers and they're doing the same thing, I do see this sort of just atrophied lower face that we're then having to go back with injectable fillers, collagen stimulators, something else, skin tightening, and in addition to that, to really mask some of that. And sometimes it takes the muscles a long time to come back. So I do tell patients with TMJ and masseter sort of symptoms, I'm just going to treat you when the symptoms come back. And so a lot of times, like you were saying, it's 6 months, it's a year, it tends to be much less frequently, but these muscles are so different. Like anatomically, they look very different when we look at them in real time. And so I'm so glad we talked about that. We talked about the DAO. How about, so tell me, lip flip.
Yeah, that's another hot one.
Yeah. And
I think that it's there's a lot of variance in why people would want to have a lip flip. So, some people come in and they have maybe too much teeth show when they smile, and they're like, okay, what can you do to help with this? How, I've heard about a lip flip. Is that something that can be an option for me? Other people, they want more volume in their lips, and they come in and ask for a lip flip. Is that going to help? So really clarifying what a lip flip is, and we can both chime in on any differences we might have, but there's 2 ways that you can inject to help with a gummy smile. The way that truly addresses, so a gummy smile basically means when you smile, your lip kind of rolls up and in, almost like a curtain kind of being rolled up like this. And there's a muscle right near the nose that's responsible for that helps that action. And for some people, it's just very strong and pulls up. A really great way to help with the gummy smile is actually injecting that muscle. You can also inject the muscle that helps us move this face, the orbicularis oris, and that's another sphincter muscle. That's really what the lip flip kind of implies. So when we talk about the lip flip, when I inject that area, it is typically along the vermilion border of the lip. And what that does is it's relaxing the muscle that helps us crease our lips, and so it creates a little bit of a subtle eversion. And I like to do that for patients. I don't think that's the best, isolated treatment for a gummy smile. I will sometimes do it in combination, but I'll usually start with one and then the other, so you kind of know when you're changing anatomy around the mouth or the functionality around the mouth, you really want to know exactly what you like, how much dose is appropriate, and a little bit of too much can feel like you don't like it. So I tend to be on the conservative side my first time treating someone, and I'll usually break that up and say, okay, first time let's treat the levator muscle, the second time let's treat the lip flip or the orbicularis. For other people, it's just more cosmetic. They want that little kind of perk, especially if you're somebody who's had lip filler. If I have someone who has full lips and they don't need or they couldn't benefit from more lip filler and maintain a natural look, I will often kind of, tie them over by doing the lip flip, which just kind of perks things up a little bit. So it's a way to kind of create that illusion of volume by getting more lip show, but not necessarily increasing the volume by using filler, which can end up looking augmented. Another reason patients will seek this area out, or I will recommend it, is that they have the little lines, a little like barcode, periodontitis. And that is something that can soften that area, but the injection might be a little different in placement for that. So depending on where the lines are pulling the most, there's little differences that I'll sometimes do it if you're making that.
No, yeah. And a lot of times I will treat the upper lip but also lower lip too. So how often are you doing both, or how do you evaluate a patient for that?
Depends on the goals. I think if it's somebody that's had, if their main concern is upper lip, I'll just address that. If they've never done anything around the mouth, I will usually start with upper lip and then add lower lip, just so they don't feel incompetent, because it really does affect the way you feel when you chew, drink, swallow, things like that. I never want it to feel like it's too much for somebody. But if you have little tiny lines, or you want your lower lip to perk out a little bit, and some people are very specific with how they want things to look, so they come in and show a picture, I want central pout, or I want lateral, pout to come down, and you can really play with that and fine tune that based on your placement.
Yeah, so, and that's fun. That's part of the fun and the art, I think, of things as well. But I tend to be pretty light-handed in that area. We do topical numbing because I think that is a spicy area to inject. So I think that helps tremendously with the injection. But we use very small volumes. When we were first exploring this area 15 years ago, people were starting with like 10 units of onobotulinum
Everyone's
toxin.
just drooling all over themselves.
Yeah, and it's like you literally had a little flabby piece of deli meat on, sitting over your tongue or over your teeth. And so, we use a fraction of that, I would say, but there is a dosage and duration relationship. So I do tell patients this is going to be one of the areas that probably wears off the most quickly. The same thing with the forehead, because we're doing lighter doses and it's not going to last as long. We know if we wall up a muscle, it's not going to come back for a while. But I think that's part of the art of it, and you are rightly so. And we educate patients that I say it doesn't affect elocution, but what it will change is just for the first 2 weeks when I've had it done, sucking through straw, brushing your teeth with your toothbrush, just getting that seal. You can do it, you just have to think a little bit about it. So just being mindful that we are softening the action of that muscle. And then the other area I would say sort of in the lower face that I have a few patients that I treat are the submandibular muscles. So I don't know if you have anybody like that in your patient population, but either very thin patients or sometimes after patients have had facial or neck surgery. They're little glands that sit right here, and you will see them kind of hanging. And especially if they're slim, you've got this sort of rejuvenated jawline, and then you've got this area where the gland is hanging there. So I'm very careful to ask about history of cavities, because if we are going to shrink that gland, it is one of the producers of saliva that's in our mouth. And if somebody has Sjogren's syndrome, where they're not making a lot of saliva, or there's someone that is more prone to cavities, I don't want to take some of that wash of the natural saliva production away. But if that is fairly clear, we will do a modest amount on either side, and it does a really beautiful job of shrinking that. So I have, just a few patients that, and again, I think it's one of those things, glandular or these deeper muscles that aren't the muscles of facial expression, I feel like I treat less frequently than I do things like the platysma or the facial muscles we've talked about in the upper half. Talk a little bit about neck beyond the front.
Yeah.
So do you have anybody you're doing like traps on?
That was another really big TikTok wave.
Yeah.
So I feel like I had a phase where there was a lot of patients coming and asking for that. I think that I still do treat that area. It's not as commonly requested by patients. I think that I'm very personally, with things like that, I'm very selective, because if you're coming in and you want the shaping effect, I think it's wonderful for that. Some people, I had a bride who just really wanted a nice swan neck look, and what we're talking about is treating this trapezius muscle, which is kind of this thick muscle you can grab right here in this area. And that became really popular, I would say like 9 to 12 months ago. You know, that you can tell, I can always tell when there's a wave of something that's trending.
Everyone
comes
more
in
questions
about it. But it can be a really beautiful area. I still think that functionally, if patients are coming in and they're doing it for pain, I'm not going to say, okay, this is your treatment for pain. And I think that's really important with these aesthetic cosmetic treatments. If you're doing it because you have pain, you need to see a physical therapist. You need to see, you know, see how the treatment appropriately worked out. And I think that that's where people can, you know, if you go to the wrong clinic, that kind of, you know, it's just, okay, I'll take your money, let's do this treatment, and you're not really addressing the why that this is happening. Versus, you know, cosmetically, I think it's beautiful for certain people.
Yeah.
So I think that's important in any area as well that we're treating. It's really, you know, you make sure somebody's a good candidate for what you're addressing.
And I think when we're addressing the trapezius muscles, you know, you need to have healthy patients. The last couple that I've treated, one is she's a spinning instructor, so she's literally like this all the time, and she could just see that her trapezius muscles were building up. She's not having pain, but it's just that she doesn't exactly, she wants to elongate the neck a little bit. And then my other patient, similar sort of situation, and I actually ran into her at the airport, you know, a couple recently. We've done it, you know, about a month or so ago, and she's like, oh my God, Dr. Palm. She ran across the terminal and was like, it helps so much. So I think that's what's so rewarding. You know, yes, we do a lot of this for aesthetics, but some of it has real functional benefits too. And, you know, just happy patients. And typically with those, we're using higher amounts of toxin. We're injecting a little bit more deeply because it's a big muscle belly bed, but it tends to last longer. I find with most of my patients it's 6 months. Sometimes they can get away with even 9 before they need retreatment.
Yeah, I agree.
So last area that is actually, you know, an area that's been studied quite well is underarm, and that's straightforward. And you know, sometimes patients have had it. I'll tell you, I do it twice a year because I lecture a lot. It's a stressful situation, and you know, whether you feel calm and amazing about it, you know, our body has a response to stress, and it's part of it is sweating, and so. I do it because I don't want to remind my stresses. So it's really easy, but I think we do some special things to make it comfortable here. So if you were doing it, the on-label, if we're using something like Botox is 100 units. If I'm doing it with another product, we're not supposed to do conversions of units, but I think we have a rough idea of what we do. So we certainly can use other products to get that same effect, but we're basically helping with eccrine gland function. That's our sweat gland, to just not produce so much sweat. And it works incredibly well. I mean, patients will say within a couple of days they notice a difference, and typically we get about 6 months of duration out of that. We typically, if we are using Botox cosmetic or Botox, we use 50 units per side to do that, but we do some cool things. We do topical numbing, we have ways of driving that in, and then we have some comfort measures that we do that I think between the needle size and some of the things that we use to distract the skin, make it such an easy area. And I think that's something that once patients have had that done, they really enjoy it and they continue doing it. So anything else that you feel like we haven't covered?
I feel like we've covered
no, I think this was great, and I think it's so timely. When I saw this, you know, at the end of last week, I was like, ooh, we were talking about like what we were going to chat about today. I said, let's talk about it, because I think there's so many cool things out there that we can do. So I think, you know, points to sort of drive home is it's just not the upper third of the face anymore, right? And I think, you know, the price of getting a toxin isn't really just the price of the toxin, it's the artist that's behind the syringe. And I think you can get very different results depending on where you go, and I think oftentimes you get what you pay for. So this is luckily one of those things that in most cases, with the exception of kind of what I've seen with overindulgent, I would say, masseter use, it usually is quite temporizing, and we have ways to kind of, you know, if you don't love something like every once in a while an upper lip flip, even at a small dosage, people just don't like the sensation. But I think that the nice thing is these don't last forever, which is lovely. So any other parting words that you would say?
No, I think that we really covered. I mean, if you guys have questions about areas, or you know, you want to have a conversation, you're always welcome to have a consultation to talk about it, because it is so individualized. You really have to do that before you can really decide if an area is for you. And it's good to get an artistic eye looking and saying, okay, this is what I would do. But I think even if you've had Botox and you've had it kind of the same way or just for it for years, what I love is just doing a fresh assessment, because we're aging. So, you know, you might not have benefited from an area 3 years ago, and now maybe it would be a benefit. So it's always good to, just like, you know, when you're getting your hair done and it's always the same thing every time, it's good to have like a little fresh assessment conversation, make sure it's all still working. And when you come in for your routine appointment, we can always touch base about that and make sure that your plan is up to date.
Yeah. And the last thing we'll note to everybody is we're doing a Nova Thread event in November, and we sent out an email, and within about an hour and a half it sold out.
Yeah.
So we're purposely keeping it a little bit smaller. We did want 100 people here, so we're probably going to do a second date. So be on the lookout for that, because we'll put it on our social media posts. We want to make sure that everybody that wants to learn from Julia and from Stephanie, and they're just real experts. I mean, you guys have been doing PDO, Nova Threads for quite some time. It's going to be lovely, a little lunch and learn, but we're going to try and find an alternate date, because everybody that would benefit from, I think, being educated by you guys would want the opportunity to exist. So stay tuned for that. We will for sure get you guys information on that. But want to thank you for tuning in, and I'm going to be old school, and I'm going to stop it myself. So we'll see you guys next time.
Low budget production over here.
And we'll see you next time for Lunch and Learn.